Rad Techs, welcome back to Analyze with Casey. Today we're diving into one of the most overlooked but high yield sections for your ARRT journey, head and face x-rays. Yep, we're talking skull, sinuses, facial bones, mandibles, and more. Whether you're in a clinic or prepping for your board, mastering this section will set you apart. So grab your marker, center at the glabella, and let's do this. Section 1, Skull and Cranial Anatomy. First up, your anatomical roadmap. The skull is not a single bone. It's a composite of 22 bones, 8 cranial and 14 facial. Let's quickly name them so they stick. For the cranial bones, you've got the frontal bone up front, 2 parietals on top and side, 2 temporals over the ears, and the occipital bone in the back, and deep within, the sphenoid and ethmoid. That's your cranial vault. Facial bone? 2 maxillae that form your upper jaw, 2 zygomatic arches that form your cheekbone, 2 nasal bones, 2 lacrimals, 2 palatines, 2 inferior nasal conchae, the vomer, and the one and only mandible, your lower jaw. These bones protect your brain, anchor facial muscles, and form the framework of your face. For imaging, we focus heavily on the frontal, occipital, and sphenoid for pathology, like trauma or congenital defects. Don't forget your positioning landmarks. These landmarks and lines are crucial for accurate skull imaging, both for getting great diagnostic images and for avoiding repeats. Let's break them down simply. Glabella, what is it? The smooth, slightly depressed area between your eyebrows, just above the bridge of your nose. Why does it matter? It's often used as a central reference point in skull radiography, especially in frontal or AP views. Think of it like your center dot for many head projections. Your Nasion. What is it? This is the junction point where the frontal bone, your forehead, meets the nasal bones, bridge of your nose. That's the bridge of your nose. So why does it matter? It's the exit point for the central ray in views like the Caldwell projection. It's also a reliable landmark because it doesn't shift with head rotation. The EAM, this is your external auditory meatus. That's your ear canal. Yep, that little hole in your ear. So why does it matter? It's a reference point for lateral skull and cranial-based imaging. You'll often align your central ray just above or in line with the EAM in lateral views. Here are some crucial imaging lines. These are invisible anatomical lines used to align the skull for accurate projections. Your OML, that's your orbitomeatal line. That is from the outer canthus, the corner of your eye, to the EAM. This line is used in the most standard skull views like Towne and Caldwell. The IOML, this is the infraorbital meatal line. From the infraorbital margin, just under the eye, to the EAM. This is used when the OML can't be used like somebody with limited neck mobility. Then you have AML. This is your acanthomeatal line. It's from your acanthion that's just below your nose to the EAM. This is crucial for parietoacanthial views, that's your water's view, to evaluate sinuses or facial bones. Then you have the GML, your glabellomeatal line. That's from your glabella to your EAM. It's used in modified projections where a shallower angulation is needed. Why do these matter for the ARRT exams and real-world imaging? If these lines aren't aligned properly, you risk misrepresenting anatomy, leading to misdiagnosis or repeated exposure. A complete skull series usually includes 3 to 4 standard projections. Each one highlights different parts of the cranium and helps evaluate fractures, pathology, or congenital anomalies. Let's break them down. First up is our PA Caldwell view. The patient's forehead and nose are placed against the image receptor. The orbitomeatal line, OML, is perpendicular to the IR. The central ray is angled 15 degrees caudal and exits at the Nasion. This projection demonstrates the frontal bone and the superior orbital rims. Our image goal is the petrous ridges, and they should be projected in the lower third of the orbits. For clinical use, this is excellent for evaluating frontal and anterior ethmoid sinuses, as well as orbital margins and skull trauma. Next up is our AP Axial Towne view. The patient is supine or erect with the chin tucked to bring the OML perpendicular to the IR. If using the IOML, increase the angle to 37 degrees caudal. The central ray is directed 30 degrees caudal to the OML and enters approximately 2.5 inches above the glabella. Our image goal here is to visualize the occipital bone, the foramen magnum, and the dorsum sellae within the foramen magnum. Watch out, overangulating can elongate the dorsum sellae, leading to diagnostic confusion. Next up is the lateral skull. Position the site of interest closest to the image receptor. Align the interpupillary line, the IPL, perpendicular to the IR. Adjust the IOML parallel to the transverse axis of the IR. It's usually horizontal. The central ray is directed perpendicular and centered about 2 inches above the EAM. Our image goal here is superimposition of orbital roofs, sellae turcica, and mandibular rami. This is a great view for general skull contour, evaluating cranial trauma, and checking for midline shifts or fluid levels. Here's a pro tip. Always check for rotation and tilt. A rotated head will show separation in the orbital roof and rami. A tilted head will misalign the cranial base. Take the time to reposition your patient. It saves from unnecessary repeat and gives radiologists what they need to make the right call. All right, next up is sinuses. Here's where positioning is everything. Sinus imaging is all about air fluid levels, so these must be done upright unless absolutely contraindicated. First up is our PA Caldwell view, done erect. Position the patient with their forehead and nose against the IR. The OML is perpendicular to the IR. The CR exits at the Nasion. Our imaging goal here is to have the petrous ridges in the lower third of the orbits. This is best for frontal and anterior ethmoid sinuses. This view gives you a solid look at the frontal bone and orbital margins while still showing the upper sinus anatomy. Next up in the sinus view is the waters, or the parietoacanthial view. You want to extend the patient's neck so that the OML forms a 37-degree angle with the IR. The MML, which is our mentomeatal line, should be perpendicular to the IR. The CR exits at the acanthion. Our imaging goal here is to have the maxillary sinuses appear above the petrous ridges, which should be projected just below the maxillary floor. This is best for maxillary sinuses, orbital floors, and facial trauma, like blowout fractures. Then we have our lateral sinuses. The patient is positioned true lateral with the IPL perpendicular and the IOML parallel to the bottom edge of the IR. The CR is directed horizontally, entering about halfway between the outer canthus and EAM. Our imaging goal here is to visualize all 4 sinus groups, frontal, ethmoid, phoenoid, and maxillary, in a single lateral image. This is best for evaluating air fluid levels, especially in trauma or suspected sinusitis. Always use a horizontal beam for sinus views. It's crucial to differentiate between mucosal thickening and true fluid levels. A tilted or non-horizontal beam can mask or mimic pathology, so keep it level and upright whenever possible. Facial bone exams are commonly requested in trauma cases and are essential for evaluating fractures, congenital deformities, or surgical planning. The views you'll most likely encounter include the waters, which is our parietoacanthial. That's where a patient extends the neck so that the OML forms a 37-degree angle to the IR. MML is perpendicular, and the CR exits at the acanthion. Our goal here is a clear view of the maxillary sinuses and orbits. Petrous ridges should lie just below the floor of the maxillary sinuses. This is most frequently used for mid-face trauma, such as orbital floor and maxilla fractures. Next up, we have a modified Waters. You're going to adjust the patient's neck so that the OML forms a 55-degree angle with the IR. MML is not perpendicular. This change helps project the orbital floors better. Our goal here is an enhanced view of the orbital floor, especially for detecting blowout fractures. This view is best for subtle orbital trauma and evaluating soft tissue. Next up, we have the lateral facial bones. You want your IPL perpendicular to the IR and your IOML parallel to the bottom of the IR. Your CR is perpendicular to the zygoma, about midway between the outer canthus and the EAM. Our goal here is a lateral profile of facial bones with superimposed zygomatic arches. This is a good view to assess nasal bones, maxillary sinuses, and general facial contour. Next up, we have SMV and tangential views. This is for the zygomatic arches. On the SMV view, you want the neck hyperextended so that the IOML is parallel to the IR. The CR is perpendicular to the IOML. For the tangential view, you want to rotate the head 15 degrees towards the side of interest and tilt the chin 15 degrees away. Our goal here is an isolated visualization of one zygomatic arch. This is used to identify depressed zygomatic arch fractures, or it makes for a great post-trauma projection. Okay, let's talk nasal bones and mandible imaging. Small anatomy, big value. All right, your nasal bones, lateral nasal bones, right and left. Both right and left lateral views are taken. Your IPL is perpendicular to the IR, and your IOML is parallel. Your CR is directed a ½ inch inferior to the Nasion. Our imaging goal here is nasal bones shown in profile along with the soft tissue nasal structures. This procedure is most common for nasal bone fractures. Use low KVP to preserve soft tissue detail. Mandible views, your PA and PA axial, that's your mandibular rami. In your PA view, you want the OML perpendicular to the IR. The CR exits at the lips. On your axial view, you're going to use the same positioning, but angle the CR 20 to 25 degrees cephalic. Our goal here is mandibular body and rami. The axial version elongates structures for better visualization. We use this for trauma, tumors, and structural anomalies. Your axiolateral oblique mandible. This position varies depending on the region of interest. If you're interested in the ramus, you want the head in a true lateral position. If you're interested in the body, you want to rotate the head 30 degrees toward the IR. If you're interested in the mentum, the chin, rotate 45 degrees. For a general survey, rotate 10 to 15 degrees. The CR is angled 25 degrees cephalic. Our goal here is a specific portion of the mandible elongated and projected clear of the spine. We use this for fractures, cysts, or infection sites. Your SMV view, mandible. For this view, you want the neck extended, the IOML parallel to the IR, the CR perpendicular to the IOML. Our goal here is symmetric mandible and condyloid processes. Our mandibular condyles and base of skull relationships is the main goal for this view. When doing the axiolateral oblique mandible series, always combine head tilt and tube angle to maintain an open IP line and keep anatomy crisp. Temporomandibular joint imaging can be intimidating, but it's incredibly important for evaluating joint function, injury, or degenerative changes. TMJ basics. These joints connect the mandible to the temporal bones. They're involved in talking, chewing, and yawning, so you need both open and closed mouth views. First up is the modified Law method. The patient is in a semi-prone or upright position. Their head's rotated 15 degrees towards the IR. The CR is angled 15 degrees caudal. centered 1.5 inches superior to the EAM. Our goal here is we want the TMJ closest to the IR shown clearly. This is a good view to compare open versus closed mouth to check for joint space movement and pathology like dislocations or arthritis. Next up is the Schüller method. You want the head in the true lateral position. The CR is angled 25 to 30 degrees, caudal, centered 1/2 inch anterior and 2 inches superior to the EAM. Our goal here is to project the TMJ inferior to the base of the skull, reducing superimposition. We also want to take open and closed mouth images to visualize condyle positioning. Instruct the patient to open their mouth only as far as comfort allows. For trauma or dislocation cases, don't force open the mouth. When in doubt, consult the radiologist. TMJ views require precise technique and patient cooperation. Always review your images carefully for motion and anatomy visibility. Let's bring it home with a quick review and image critique, because it's not just about taking the image, it's about knowing what makes it diagnostic. Key landmark recaps: Glabella, Nasion, EAM, nowhere to center. Your OML, IOML, AML, GML. These lines guide every single head projection. All right, here's a view review. Our Erect Caldwell is used in frontal sinuses, orbits, and you want the petrous in the lower 1/3 of the orbits. On the Towne image, we want the occipital bone and the foramen magnum. On the waters, remember maxillary sinuses and orbits. On the lateral, your side profile of skulls or sinuses and all 4 sinus groups. On your nasal lateral, soft tissue and nasal bones. Mandible, know your rotation angles for each region. TMJs, always compare open and closed. Modify technique if trauma is suspected. Here's some common mistakes to catch. If you have rotation in your laterals, it will look like double orbital roofs or rami. If the petrous ridges are too high or low in the water's view, you probably have the incorrect OML angle. If you missed sinus fluid levels, the patient's not upright or the horizontal beam was not used. If your mandible's superimposed on the spine, the head's probably not rotated properly in oblique. You made it to the end. Yes. Drop a hashtag head x-ray master in the comments so I know you're part of the squad. Want more? Check out my PDF in the description for an outline of all my ARRT videos. And drop a comment. Let me know which one you found the most helpful, if you want more quizzes, or if you want more Canva outlines. And hey, did you also know I've trained a custom GPT just for you? It's called ARRT Study Coach Analyze with Casey. It's like having me in your pocket 24/7. Whether you're brushing up for the ARRT boards, CQR, or recertification, this GPT is built to break it down in plain language, quiz you, and guide you all the way to passing. Comment below if you'd like the link to the custom GPT. Remember, every image you take matters. You're not just checking boxes. You're catching pathology, guiding treatment, and showing up like a pro every single shift. Until next time, keep shining and keep scanning. You got this.